Hello and welcome to a special interview for The Wire. Today we present an informed opinion from outside India. What does one of the world's most highly recognized public health experts think of the way India is battling COVID-19? That's the key issue I shall explore today with Professor of Global Health and Director of the Harvard Global Health Institute, Ashish Jha. Professor Jha, let's start with the big picture facing India today. As of this morning, Friday the 28th of August, India has nearly 3.4 million cases. It's growing at slightly over 77,000 a day. And for the last 5 days, India's had 50% more cases per day than both America and Brazil. Is this worrying? Or given the size of the population, 1.38 billion, was this only to be expected?
Well, thank you for having me back. And I am delighted to be here and speak with you. You know, when I look at the big picture in India, on one hand, there is, to some extent, this was expected, right? We are a big country, many people, 1.3 billion people across the nation. So the fact that there are a lot of cases in India is not surprising. But the fact that now India is generating more cases than any other country in the world, while it was on some level predictable, I think it still represents a real problem. And I am worried that in the days and weeks ahead, those numbers will continue to increase. And it represents a lot of people getting sick and a lot of people suffering and dying.
I want to pick up on that last point you made, that in the days and weeks ahead, the numbers are going to rise. When I interviewed you last on the 20th of June, at that time, India was increasing by 13,000 cases a day. And I remember you saying to me that you estimated that by the end of August, India could be increasing at almost 200,000 a day. That would be a total of both the reported as well as the unrecorded cases. Now, today we are at the end of August, and the official tally is just over 77,000. What do you believe is the total tally, both the official and the unreported taken together?
Yeah, it's a good question. Of course, no one knows for sure what the unreported number is because it is unreported. But when you look at the very best models out there, the very best data, and make estimates, the very best model, I believe, for looking at these issues globally is the GU model by Yang Gu in the United States. And that model estimates that there are 500,000 cases a day happening in India right now, or 5 lakhs a day. And we're only picking up about 75 or 80,000 of that. So about 15%, missing 85%. That to me is, that may in fact, again, that's probably the best estimate. That may in fact be the right number. But whatever it is, even if that's an overestimate, it is very clear when I look at the data more national across the country that India is missing a vast majority of the cases. I would certainly believe that it's well over 200,000 total in terms of new infections that are happening every day.
Just for the sake of those who didn't get the name of the model, was it the GU model? Is it GU?
GU. Exactly. And I can share with you afterwards a link to the model so you can also share it. But the point is, it's widely available. It is widely respected and looked at by policymakers, not just in the United States, but really around the world.
But assuming that the GU model is correct, and you certainly have faith in it, as you pointed out, we're missing 85% of the cases. That's a huge number to miss. Does that suggest that India is nowhere near testing enough?
India is not anywhere near testing enough. So right now, when I look across the nation, the percent of tests that are coming back positive is around 8 or 9%. That's a very high number. Where you want to be is around 2-3% or even lower. And the higher the proportion of of tests that come back positive, it means you're missing more and more cases. And so if you look at a country like South Korea right now, its percent positive is less than 1%, meaning it has to do more than 100 tests to find one positive case. In New York State, the percent positive is about a little less than 1%. Again, 100 tests to find one positive case. In India, where the test positive is, let's say, 9%, that means that for every 11 tests it does, one comes back positive. that's usually a sign that there are many, many cases out there that are being missed if you're finding cases so easily. And so I have no doubt in my mind that a vast majority of cases of the coronavirus are not being identified right now in India.
Now, not so long ago in America, the Center for the Disease Control said that for every officially recorded infection in America, there were probably 10 more that were not recorded. On that principle, if India has almost 3.5 million officially recorded cases, does it mean that the unrecorded must be 35 million, or would that logic not apply in India?
No, I think that logic largely does apply. This is why when I said India were missing 85% of the cases, that's another way of saying out of, every case that we're finding, we're missing another 6, right? Or another 5 or 6. That's what that implies. And I believe that is true. And so the question, of course, people will ask is, how do you know? How do you know that that's the number? There are many ways of triangulating, but certainly looking at percent of tests that are positive is one way of estimating how many cases you're missing. And in the US, I believe that we have probably over time missed 80 to 90% of cases. That has also been true in Western Europe. Some countries like Germany, which have had a very robust testing program, have done better. And I have no question that if that's what's happened in the US, that's what's happened in much of Western Europe. There's no reason to think India somehow is not feeling the same set of conditions. So yes, I believe that the true number of people infected in India is probably well over 30 million. It could be even twice that. We don't know, but what we know is that it's a much, much higher number than the official cases.
So in fact, the true number could be possibly, I underline that word possibly, as much as 70 million, double the 35 million we mentioned earlier.
Yeah, and part of it is you can see this from some of the serologic data, the antibody testing that has gone on in places like Delhi and Mumbai that find very high rates of people with antibodies, really suggesting that there's been a lot more infection than has been captured by the official data.
Now, I want to come at this point, Professor Jha, to something that we discussed in June with a certain amount of apprehension and anxiety, because now it is actually starting to happen, even accelerating. The incidence of the disease has moved away very substantially from metropolitan centers like Delhi and Mumbai, and is increasing in tier 2 and tier 3 towns, and is moving rapidly into rural India as well. Now you know the state of the Indian healthcare system. Are you worried about what could happen in these areas? Or do you get some measure of comfort from the fact that here in rural India, the density of population is considerably lower than urban India, and that might be a saving factor?
Yeah, so there are a couple of parts of that question, so let's break them apart. First is, yes, when we spoke in June, it was, I think, quite predictable that what would happen is that the center of the cases would move from, it would start in places like Mumbai and Delhi and Chennai and other major metropolitan hubs, because those are the places that are both would get seeded first, because those are the international travel hubs. Those are the economic centers of India. And then they're also very, very dense, and so the cases would spread there first. And so it was completely predictable that that's where it would start, and over time it would get into other parts of India. And of course, what happened with migrant workers at the time of the lockdown only accelerated that. And so we discussed how I expected by August, places like Uttar Pradesh, but places like Bihar, where my family is from, Jharkhand, but other parts of India would see many, many more cases. That has in fact played out exactly as predicted. And so we continue to see a lot of cases in these places. Now, in places, and let's just talk about Bihar and UP as two very populous, relatively poor states with large rural areas, as well as urban centers, is that what I have expected is that in the rural areas of these places, of these states, case growth would go slowly. Because of that lack of density, you would not see these massive spikes, but you would see the spreading of the virus more slowly across district towns and in the rural villages as time went along. And I think that is exactly what we're seeing. The big worrisome factor, of course, is that the health systems in these places, as you pointed out, are really quite weak. When I think about, Madhubani, the district town where my family is from, and the last time I was back there and thinking about the doctors that people go to, the average person goes to, a majority of them don't have any medical training, and they're, what we call quacks, right? That represents a lot of the healthcare workforce. They don't have training in how to manage coronavirus. Can they get testing for coronavirus? When I think about the hospitals in that region, some of them are okay, but many of them lack very essential basic services. So I am very worried about what will happen as the virus continues to spread in places like Madhubani, in Bihar, in UP, in Jharkhand, in Orissa, where, again, we're seeing a lot of cases happening. These are not Mumbai and Delhi with a lot of very high quality hospitals.
So to sum up what you're suggesting, and I'm getting confirmation from you, is that the low rural density in UP and Bihar may save people because the spread will be slower, but the appalling, and I'm using that word deliberately, the appalling healthcare system could make up for what the low density saves.
I think that's a fair way to describe it. Exactly. We've discussed this before. India's underinvestment in its health system for decades is really catching up to us. And the cost of that is really catching up to us. We don't have strong primary care. Our hospitals are not, again, I'm not talking about world-class hospitals in Delhi and Mumbai, which are superb. But I am talking about in places like rural Bihar. If you got sick, the hospital you would go to is not where it should be. And a large part of that has been inadequate investment, I believe, from the government, from the public sector. We have been underinvesting in health for a very long time. And now in the middle of the world's greatest health crisis, I think the cost of that will be borne by the people of these states.
Absolutely. The cost will be borne by the Indian people. With this in the background, because I think it's a wonderful analysis of the situation we face today, with this in the background, look down the road for me. In 2.5 months' time, almost precisely, India will be celebrating Diwali, and that it is clearly one of the most important days in the calendar for 80% of the country.
Yep.
How many cases do you think we'll have on November the 14th as we should be lighting diyas for Diwali?
Yeah, it is now predictions are getting harder. So let me tell you what I think are some opposing forces that make it difficult for me to give you a number. But I will give you, because you're asking, I will give you a number anyway. But I will tell you that my uncertainty is high. On one hand, let me talk about a little bit of good news, which is that we have seen high number of infections and probably some level of population immunity in a lot of the big centers, the Delhis, the Mumbais, the Chennais. And we can come back to talking about immunity and herd immunity in a bit, but I think that will make case growth slower in those places. But when I look at the populations of Bihar and Jharkhand and Uttar Pradesh and Orissa and much of the north, but even parts of the south, there is a long way to go. Where a proportion of people who've been infected is still quite low, but that case growth is continuing. And when I look at the prediction models, they basically suggest that the RT, the reproduction rate of cases in India, is at about 1. Some models say it's a little above 1. Some models say it's a little below 1. And so if you just put all of that together, you would predict that the true number of cases in India would be relatively flat. So I started off earlier saying I think it's going to go up. I don't think it's going to go up dramatically. So I don't think we will have 200,000 or 300,000 identified cases a day by November 4th. I think that is too much, and I doubt that is going to happen. But I think it's still going to go up some, and I certainly wouldn't be surprised if the number of identified cases on November 4th is, let's say, 100,000, 1 lakh a day. And again, continue to have lots of unidentified. How many unidentified will also be driven in part by how good the testing is. India is actually doing a reasonably good job of testing in terms of sheer numbers, but it has to do a lot more. It continues to undertest for the size of the problem it has. So I'm not trying to avoid your question. It's a hard one. It's harder now than it was in June. But I suspect, certainly I don't expect numbers to be coming down anytime soon nationally. And I expect that those numbers will continue to grow, but probably not at the same pace that we've seen over the last couple of months.
Let me, for the audience, tease out what I think is an element of good news. We are growing at the moment at just over 77,000 official cases a day. You expect that around November 14th, when Diwali happens, that's just 2.5 months down the road, it will be around 1 lakh official cases a day. You don't think we're going to be reaching levels of 2 or 3 lakh official cases a day?
That's pretty fair description. And of course, depends a lot on policy and what happens between now and then. But that's right. And so Diwali, you said November 14th. Yeah, so 2.5 months from now. I think that's a pretty good summary of where I expect us to be. Higher than today, but not dramatically higher.
Just because people are curious about these statistics, sometimes people take a sort of perverse delight in knowing the details. If you believe we could have possibly 70 million total cases at the moment, detected and undetected, what would be the total number come November the 14th? I take it at least double 70 million, if not more.
Yeah, if not more.
So we could be very close to a total of something like 200 million detected and undetected cases by Diwali.
It's possible. I think those are, it's part of the difficulty here in these estimates. And by the way, so part of the difficulty here is that we don't have very good data from places like Bihar and UP, which are these massive population centers. And so we need a lot more data coming from these places. We need more serosurveillance data. We need more antibody testing data from these places in order to make more refined estimates. But the idea that the true number of cases is 10 to 20 times the official number would be completely consistent with what we have seen in other countries. So in Spain, for instance, we think the true number of cases is about 10 to 12 times the official number of cases. As you mentioned, in the US, the CDC thinks that the true number of cases is about 10 times what the official number is. So I have no reason to believe that India is not at least 10 times the official, but it could easily be 20 times the official.
And remember, I'll just point this out for the audience, that the estimate, and it is only an estimate, that we could have 200 million detected and undetected cases by Diwali in 2.5 months' time, is based upon there being 10 times the official number. 20 times the official number would double the 200 million, pretty close to 400 million.
Yeah, so if we say it's 35 million now, let's say at 10 times the official number, 200 million by Diwali would require sort of almost 5 or 6 times current numbers. That strikes me as maybe a lot. So maybe not, I sort of think more if it's 20 times the official number, so let's say it's 70 million, then it could easily be double or triple that by Diwali. So either way, we're looking at a lot of cases. And by the way, even at 200 million, that would only represent about 12-15% of the Indian population.
Absolutely. The total population is 1.38 billion. 200 million or 300 million on its own sounds ginormous, but as a percentage of 1.38 billion, it's only, as you said, 10, 12, 13%, and it's much more understandable. One more question about the future. In June, when I spoke to you, you thought India was unlikely to peak before November. It could be even a little later. Is that still your feeling?
Yeah, there are some data, some models that suggest that India may be peaking now or peaking soon. As I look at the data, I think it's possible. But certainly, it's also entirely possible that we'll continue to see small increases. So let's say we're at 77,000 new cases a day. I would not, as I said to you before, I would not be surprised if that continues to tick up and up every day. So by mid-September, it's at 85,000 a day. By October, it's around 90,000 a day. So slow increasing number of new cases. I don't know that I see much evidence that we're going to start seeing a decline in cases in India anytime soon. And I think as we continue doing more testing, and if we get better at identifying a lot of those unidentified cases, that will also make that a reality.
So what you're saying is that we are not likely to see dramatic increases in the daily rate, a slow, steady increase. But it does seem from what you're saying that the peak will be, as you said, in June, sometime around end of October or November, maybe end of November, thereabouts.
Yeah. Yeah, that's my best guess based on the data. That's what it was back in June. And I think that's right. And we will see. And there are some very good modelers who think it might come a little earlier than that. And they could be right. I think, but the most important message here is, let's say even peaks at the end of September. It's not going to come dramatically down. So the bigger point is that we are going to be continuing to generate a lot of new infections every single day for many, many months ahead. And lots of people continue to get sick, lots of people continue to die in the weeks and months ahead. This is not behind us, and this is not about to turn around anytime soon.
That's the very important point you're making, that even if it were to peak by the end of September, it's not going to dramatically come down in terms of the cases. We will be generating a lot of cases for a lengthy period of time. In other words, we'll have plateaued out at a high level for a long time.
Exactly. That's why I don't worry quite so much about, is it exactly the peak? What I really question is, are a lot of Indian people continue to get infected on a daily basis? And are people continue to get very sick and die on an ongoing basis? And if the answer is yes, even if the peak has already happened, unless those numbers are coming down very quickly, it continues to represent a very big public health problem.
Let's come, Professor Jha, at this point to two things that you mentioned a little earlier. You talked about the serological surveys that have been done, and you mentioned herd immunity. I'll try and combine them into a set of questions. Several cities, as you said, have done serological surveys, and they show a fairly high percentage of the population has been exposed to the virus. It's 29% in Delhi. In Bombay slums, it's 50%. In parts of Pune, it varies between 36 on the low side and 65 on the high side. In Amritsar, it's 40%. Now, I know these are just limited areas. Geographically, they're by no means enormous. Nonetheless, how do you view these results, and do they suggest that at least these limited centers are approaching herd immunity?
Yeah, these are very good questions. So it's a bit complicated, and let's again break it down. When I see numbers like that, 30%, 40%, 50% of people having antibodies, those are very, very high numbers. In New York City, which was hit very hard by the virus, very, very hard. My best estimate of the serologic data from New York is that maybe 25% of people were infected. And I don't know that Amritsar was hit as hard as New York. I don't know that even the slums of Mumbai were hit quite as hard. So why the higher numbers in these places? What we've seen from a lot of these serologic surveys is that the quality of the test you use, the way you do the survey, who you go and study, who you survey, can make a dramatic difference in what rates you get. So that's my way of saying, I suspect that these numbers are a little high, that the true numbers are lower than that. But let's not worry about it excessively. So let's say it's not 30% in Delhi, it's maybe only 20%. Let's say it's not 50% in the slums of Mumbai, it's only 30%. Those are still high numbers. Those are still high numbers. And what I suspect is happening is that, in fact, there have been a lot of infections in these places. And what you're starting to see in these places is a change in the dynamics of the disease. So let me explain what I mean by that. Herd immunity is not a magical number that somehow you hit it and everything overnight gets better and you wake up the next morning and the virus is gone. That's not what herd immunity is. When you start approaching herd immunity, the infections start naturally slowing down, because the point of herd immunity is that an infected person now is coming into contact with many people who already are immune. And so they're not able to transmit the virus as easily. And so the transmission starts naturally slowing down. So one of the reasons that it could be that we're seeing some slowdown in cases in places like Delhi and Mumbai to some extent and others is that there is enough population immunity that while cases continue to happen there, they're not kind of growing exponentially. That, by the way, would not be true in places like Uttar Pradesh, where we think that the proportion of people who've been infected is much, much lower. It raises the second question you've brought up, which is what is the level of herd immunity? And this is an area where there's a lot of controversy and a lot of disagreements by people. Some people think it's 60, 70% infected. Other people think it's much lower. And the short answer on that is no one knows for sure. 60 to 70% infected is what the traditional models would predict. But I think all of us feel that the true number is definitely lower than that. I don't think it's 20, 25%, but it's maybe 40 or 50, and it probably varies from location to location based on the dynamics of the population. In places where people are very active and the whole population is very active, it might be higher. In other places where a small proportion of the population is interacting all the time and many other people are at home, it may be much lower. So it's going to vary from place to place. But the big picture for people is to think that in places like Delhi and Mumbai, there's enough immunity now that we don't expect massive growth in cases anymore in some of those places. I do expect growth to be much slower because of population level immunity.
In the context of herd immunity, and particularly in the context of the fact that Bombay, Delhi, Amritsar have shown in their serological surveys fairly high levels of exposure, even surprisingly high levels of exposure. In that context, let me bring up Dr. Carl Friston's theory of immunological dark matter, which apparently suggests that 50% of any population is not susceptible to any virus. Do you buy that?
I don't. Largely, I don't. We have to look at the data on this. And the idea that 50% of any population is not susceptible strikes me as not, there have been plenty of outbreaks, for instance, where in a room of 100 people, 80 of them ended up getting infected or 90 of them ended up getting infected. So there are plenty of instances I can point to where in any population you've seen very, very large outbreaks that go well beyond 50%. So that's one part of this that makes me skeptical. On the second question that's related is it possible that some proportion of people have natural immunity to this virus? Absolutely. It is entirely possible. Do I think it's even remotely possible that it's 50%? I have seen no data whatsoever to suggest that that would be the case. And so people love speculating about these kinds of things. I don't know any serious immunologist who talks about immunologic dark matter. There is a certain level of immunity that people have to different viruses based on other viruses that they've been infected with. But that number strikes me as very, very high and unlikely to be the case in this situation.
One more question about the serological surveys and the level of immunity that suggests maybe building up possibly the beginnings of herd immunity in these cities that we're talking about. It also means that there are a lot of people who've been infected and were or perhaps still are asymptomatic carriers. How infectious is an asymptomatic carrier? Or do we not have a clear answer to that question? Because I notice the literature seems to vary fairly widely.
Yeah. So here's what we know about asymptomatic carriers. There are two groups of people. So first of all, we think about half of all the spread of this virus comes from people who don't have symptoms. So if just because someone doesn't have symptoms does not make them safe from spreading it to other people. Half of all infections come from people who don't have symptoms. Okay. Now, what happens is many of those people will go on to develop symptoms later. So it might be that, let's say I was infected 5 days ago. Today, I may have no symptoms, but a lot of virus, and I might spread it to lots of people. I would be an asymptomatic spreader. But tomorrow or 2 days from now, I might go on to develop symptoms. So those people are called pre-symptomatic because they are spreading it when they don't have symptoms, but will later go on to develop symptoms. Okay. There are some people, we think 15-20% of the infections, who never develop symptoms at all, who just feel fine throughout the whole process. How much those people spread, we don't know. We think they spread some, but there is some reason to believe that maybe those people spread a little less. So the truly asymptomatic throughout the entire disease course, they probably spread some, but maybe less. But from a functional policy point of view, on any given day, there are plenty of people walking around who feel fine, who have no symptoms, who are able to spread the virus quite efficiently. And that means, this is why we suggest everybody wear masks. This is why we suggest people don't gather indoors, even if you feel well, because you could go on to spread the virus, even if you're feeling completely normal today.
But you made a very important and I think interesting distinction between the pre-symptomatic and the asymptomatic. The pre-symptomatic being people who do go on to develop symptoms. They are major spreaders, particularly before they develop the symptoms because they're moving around and meeting people. But those who remain asymptomatic right throughout, you seem to suggest it's possible they don't spread as much as others. They may not be big spreaders of the virus.
Yeah, as much. And this is controversial. So there are some studies that suggest that the people who always remain asymptomatic spread less. There are other studies that say, well, no, maybe they spread as much. My best read of the literature is if you remained asymptomatic throughout the entire disease course, you probably spread less. Not the same as you never spread. And of course, important to come back to, pre-symptomatic, the people who will go on to develop symptoms later, you can only identify that in retrospect.
Absolutely.
Right? But on any given day, you don't know who's spreading. And it could be that they will develop symptoms 3 days from now, but they could still be spreading today.
But Professor Jha, you shed light on a very important concern that was being raised in the media and by the government each time these serological survey results were produced. The debate would be, is this good news because the number of people who are infected is fairly high, 30%, 40%, or is it bad news because it suggests that 60, 70% are still vulnerable to the disease? You're now suggesting that actually the asymptomatic people who could be a danger or a continuing danger to that 60% who remain vulnerable are not such big spreaders. And therefore, if you look for a balance between is it good or bad news, the balance seems to be this is more good news than bad. We are moving towards
I agree with that.
And safety.
Yeah, I agree with that. And so if let's say we don't know because of some of the vagaries of the studies, but let's say for a second that 25% of people of Delhi have already been infected. Is that good news or bad news? I would say that's relatively good news for two reasons. One is that means there's now starting to develop enough immunity in the population. We're not going to get to herd immunity at 25%, but it does mean that the virus starts slowing down a little bit because anybody who's infected is now much more likely to come in contact with somebody who's already immune than they would have been when the infection rate was only 5% or 2%. So that's good news in that way. And the second way it's good news is if 25% of people have been infected, it means that the proportion of people who are dying may be lower than we think because that denominator is higher than we think. So there are many reasons why I generally tend to see that as good news. But that said, it is, even in a place like Delhi, it would mean 75% of people are still vulnerable. It would mean that a lot more people can still get sick and die. And we have to keep our disease control measures in place.
One more issue before I take a quick break. I want to discuss with you India's mortality rate. As of this morning, it's 45 per million. But the truth is, the mortality rate of our neighboring countries is even lower than ours. In fact, in the case of Sri Lanka, it's just 0.6 per million. And the second truth is that the mortality rate of all these countries, Nepal, Sri Lanka, India, Bangladesh, Pakistan, is hugely different to the mortality rates you've seen in Europe and America. And what I want to ask you is, how do you explain this incredible difference in mortality rates between Europe and America on the one hand, and these countries of the subcontinent, and you can add to that Malaysia, Thailand, Philippines, they all have similarly low mortality rates. Is the difference explained by the much younger age demographics of the population? Or is it also explained by the fact that these are countries where infections and viruses are much more common than in Europe and America, and so there's a certain level of innate immunity in the people?
Yeah, it's a good question. There are a few different explanations, I think. First of all, in general, I don't look at population level mortality rate in the middle of the outbreak so closely, because it's changing. There are still a lot of people out there infected right now, and many of them are going to die. And so, so we have to kind of look at this data statistic kind of as a single snapshot without reading too much into it. But right now, the numbers are relatively low in India. So what could explain it? One is, I think, vast majority of the Indian population still has not been infected, right? So even if we take that 70 million number of true infections in India, which would be very high, be 20 times the identified cases, that's about 5% of the population. Whereas we think in other countries, it's a much higher proportion of people who've been infected. So India's number of people getting infected is still early in the days. We're still moving. Cases are still spreading across much of India in a way that's much higher than where we are in Europe and the United States, certainly Europe. Second, I do think a younger population is obviously helpful. We know younger people are much less likely to die. On the issue of, is there more innate immunity in India than there is in Italy or Spain or the UK? This has been speculated from the beginning of this outbreak. And the short answer is, I don't know. It's possible that there's a little bit more, but I don't think it's a major factor. I don't, for instance, think that somehow 30-40% of Indian population is immune to this disease in a way that would not be true in other countries. So if immunity is any part of this explanation, I think it's a very small part of the explanation. But the short answer is, I don't know, because I haven't seen any data that makes me believe that that's what's going on. The last thing I will say is, part of the reason why places like Sri Lanka and Bangladesh and India look so good compared to Germany and France and the UK is case ascertainment. What proportion of our deaths are we actually identifying as coronavirus deaths? The proportion of people who die, who get an autopsy, or who've gotten tested before they died, or have very good surveillance, is, I think, much lower in places like Sri Lanka and Bangladesh and India than it is in Germany and France and the UK, who have a very developed, sophisticated surveillance system. So my best guess is we're actually missing a lot of deaths in India.
In other words, you're saying, but in very polite language, that there is very significant undercounting of COVID deaths happening in all these countries where the mortality rate prima facie looks very low. And just so that the audience can understand the level to which possibly, I underline the word possibly, undercounting is happening, there was an article in the Hindu newspaper in India on the 10th of August, which suggested that the undercounting in India was by a factor of 5.29. And to illustrate, they said the official death toll acknowledged by the government on the 31st of July was 35,747. But they believe the actual death toll, when you add in the undercounted deaths, is actually 188,939. In other words, we've undercounted by something like over 150,000. And if you extrapolate, and extrapolations are dangerous, but if you extrapolate, then the official death toll today, as I speak to you, is 61,000. If you're undercounting by a factor of 5.29, then the death toll becomes over 300,000. I don't know if those extrapolations and those calculations are correct, but that's the extent to which some people believe there could be undercounting, and that could explain this low mortality rate.
I think that is entirely possible. And let's be honest about this. When I think about, and again, I'm going to go back to Madhubani, the district town where my family's from, and when I have spent time there, we all know what happens in places like Bihar, like UP, where somebody dies at home. There isn't an automatic autopsy. There isn't automatically testing of that person. There are many, many, many people who die where we don't know the cause. And that, in fact, represents a very large proportion of deaths in India. And so it would be completely not surprising to me if the true number of deaths was substantially higher. Again, I haven't looked at that analysis by the Hindu, but the idea that it could be 5 times higher does not surprise me. It certainly seems to me to be within the possible range. So I do think there is a lot of undercounting in many, many countries, and India being among them. We don't have, I think we have to be honest with ourselves, we don't have a strong disease surveillance system. We don't have a strong death surveillance system, certainly in many, many states. And that really makes it difficult to know what the true number of deaths is.
Let's take a break at that point, Professor Jha. In the very limited time available to me in part 2, I want to talk to you about how much immunity is conferred by an infection. Can you get the infection twice, as has been suggested by the recent research released by Hong Kong University on Monday? And finally, what does that tell us about a vaccine? If you can get the disease twice, and if the immunity from the disease is only 4 months, might a vaccine only be efficacious for 4 months? But all of that in a moment's time after this break. Welcome back to a special interview for The Wire. I'm talking to one of the world's most recognized public health experts, Professor of Global Health and Director of the Harvard Global Health Institute, Ashish Jha. Professor Jha, let's come to that critical question. How much immunity do you get if you get infected, and how long will it last? On Monday, Hong Kong University has confirmed the first case of what's called human reinfection, and it's happened just 4.5 months after a 33-year-old person got infected the first time. So let me start by asking you, were you surprised that a person could get infected so very quickly after the first infection, or were you expecting this?
So I was expecting it. If I was surprised at all, I was surprised that it took that long for us to identify somebody who has been reinfected. And let me explain why. The reason I was expecting it is that viruses, when they cause infections, rarely create what is called sterilizing immunity. Sterilizing immunity is you can never get the virus again, or you won't get the virus at all. What happened in this case was the person looks like they were reinfected with the virus again, and they were fine. They felt well. They didn't have symptoms. They weren't sick. They were picked up on screening. That's actually what we expect from the immune system, is we expect the immune system to respond that second time. And it may not be sterilizing immunity that completely prevents the virus from taking hold, but it will prevent the virus from making you get sick. He didn't get sick that second time. Now, it's one case, and there are important issues that are still that we don't know. We don't know how often it happens. This happened 3.5 months, I think, after his initial, 3.5 or 4.5 months after his initial infection. That, to me, is not completely surprising. And I will come back to what the implications of all of this are in a second. Second, what we don't know is whether the virus that was found in his nose, the infection, whether he can spread that to others, because that depends on how much virus there was. And the best data that we've seen out of this suggests that he did have enough virus that it's possible he could have spread it to other people. So that, again, that's one case. And third is that he had no symptoms, but we don't know if other people, if they get reinfected, will also have no symptoms at all. But I guess the bigger picture point here is, this is to be expected. It seems to be infrequent. We expect this from other viruses. And the fact that he didn't get very sick the second time around is more or less in line with how immunity from to viruses tends to work. The first time you're at most risk of getting sick. The second time you should have much milder disease. A third time you might have nothing at all. And over time you truly build up immunity. Immunity is rarely a one time and you're completely done for life.
Can I just tease out what I think is the element of good news in that answer? The fact that the second time this person got the infection, he didn't get sick. He was simply asymptomatic. He got picked up on screening, but he felt fine. And that's
exactly.
two things, if I understood you correctly. This is how viruses tend to behave. It's not unusual for a person to get a second infection. After all, with influenza, people get frequent infections right through winter.
Yep.
And the second thing is that we don't know how many such people there are, but as of now, there's only one person been found.
Yeah, and I expect over the weeks and months to come, we will find many other people. Again, there have been at least 24 million people in the world who've been officially identified as having been infected. This is the first official reinfection, but I wouldn't be surprised if in the days and weeks ahead we see many more. What I would worry about is if that second time people are getting very sick, that would concern me more. If those people are spreading the virus very substantially, that would concern me more. But this is exactly the kind of thing we expect from a virus like this.
Does this give us any hint about what to expect if there's a second wave of COVID-19? I know that the first wave isn't fully over, so it's a bit premature to talk of a second wave, but does it give us any hint of what will happen when there's a second wave?
Yeah, I don't know if I even think about first and second waves anymore, because I feel like in many ways we're still living through the first wave, just coming to different places at different times. But to the underlying part of your question, which is imagine that there is a big uptick in cases at some point down the road. Let's say in December, January, February, a little bit colder, people are spending more time indoors, and you get a big uptick. What happens there? So first of all, there's a lot we don't know. What I suspect is you're not likely to see a lot of people who were previously infected get sick, but I would not be surprised if some chunk of people who were previously infected do get reinfected. And then again, the big question of can they then transmit it to other people? We don't know. It's possible. This is all the more reason for making sure that we're protecting people. People are wearing masks. People are not congregating indoors. Is we should not look at infection as a one-time and you're done and then you're immune for life. That is highly unlikely, and this case is really highlighting that.
In which case, if the immunity that is conferred by an infection lasts roughly for 4 or 5 months, and there was a King's College survey that suggested much the same thing too, what does that say about a vaccine? How effective will a vaccine be? Might it be the case, as Dr. Fauci, I believe, said in America, that it's very unlikely we're going to have a 100% effective vaccine. And therefore, we're going to have to get used to an idea that the vaccines that come up will be roughly 50-60% effective.
Yeah, so this is really important, and let's talk about the vaccine, because I think there's a lot of magical thinking about the vaccine. There's a magical thinking that soon we will have a vaccine and we will all go get vaccinated once, and then everything will be fine. We'll be back to life before this coronavirus. And what I can assure you is that's not how this is going to play out. Now, it is theoretically possible that a vaccine could be 95 or 98% effective, but that is highly unlikely. Highly, highly unlikely. Of course, I hope it is, right? I hope it's 100% effective, but I think that is highly unlikely. So let's assume that a vaccine is maybe 70% effective at preventing infections. There will be these questions of how long is that even going to last? It may mean that you need a couple of doses of the vaccine to build up enough immunity to last you a year. Second, it will mean that while the pandemic, if it's 70% effective and large proportion of the population gets it, it will have a very dramatic effect on the level of population immunity. It will dramatically slow the spread of the virus down, but it won't make it go away. And it may mean that for some period of time, as we continue to improve the vaccine, as we continue to learn more about the virus and get better at treatment, that we will continue to have to wear masks. We will continue to have to avoid large indoor gatherings and be more careful and continue washing hands and maintaining a modest amount of social distancing. Nothing like a lockdown, but maybe the behaviors that we did 2 years ago or last year. I've been to many mandirs, many temples where there are hundreds of people jam-packed into a small space. Maybe that we will not want to do for some period of time, even after a vaccine, because there still will be enough susceptible people. So I just don't want people to think that a vaccine is a magical kind of silver bullet that brings everything to an end. It won't. One last thing, I do believe that we will be able to get to a point with vaccines where enough people have enough immune response that maybe we have to get a booster shot every year, but that you'll have a good amount of immunity for at least 8 to 12 months so that you don't have to be getting vaccinated every 4 months.
A booster shot every year is not that disturbing because if I'm right, for the influenza vaccine, you have to have it every year. This should be very similar.
Exactly.
What
And that's what I expect.
What do you then make of the fact that the Russians have announced they have a vaccine which they call Sputnik, and Putin's daughter apparently, according to the papers, has taken it. The Chinese claim they have one which is being given to health workers and armed forces personnel. I mean, if these are real efficacious vaccines, they've been developed at incredibly fast speed. What do you make of this news? Are you disbelieving?
So what I like to say to people, first of all, we should acknowledge the vaccine development has been unbelievable, so fast and so well done. In general, I think the scientific community has been extraordinary in how it has handled itself on the vaccine and should be applauded. Second is people ask me, what do the Russians have a vaccine? What do you think of their vaccine? And I say, everybody has a vaccine. I mean, America has many vaccines. Europe has many vaccines. We just don't know if they work or not. We just don't know if they're safe or not. India has a vaccine. It's just, is it a safe and effective vaccine? We don't know. The same true with Russia. They basically skipped their phase 3 trial. We have no idea whether the Russian vaccine is effective, and I have no idea whether it is safe. So does Russia have a vaccine? They don't have anything that the rest of the world doesn't. They've just decided to forego a careful analysis to see if the vaccine actually works or not. They're doing those trials now, they say. But the bottom line is that it is, I think, incredibly dangerous to be pushing out a vaccine when you don't know if it works well or not, and when you don't know whether it is safe or not. And I am, of course, a very big proponent of vaccines. I believe vaccines are among the world's most amazing lifesavers. But if you don't do it well, vaccines can be dangerous. There's something called antibody-mediated disease enhancement, or ADE. In this, and we've seen this with some vaccines, where if you get the vaccine that is not safe and then get exposed to the virus, you could end up having much, much worse, much more severe disease. So we want to make sure that the vaccine doesn't do that before we give it out to millions of people. This is why we have to study vaccines, is we want to be very thoughtful and careful about both the effectiveness and the safety of the vaccine. Now, I believe that one of these coronavirus vaccines, maybe many of them, will end up being very safe, will end up being very effective. But my belief is not evidence. We've got to generate the evidence before we make that declaration. Russia decided to declare without the evidence.
In which case, let me ask you this, Professor Jha, if shortly after this interview goes on air, you receive a telephone call from President Putin who says, I heard you on the wire. You're the sort of person we must ensure keeps alive. I want to offer you Sputnik. Would you accept gratefully, or would you think very hard of polite ways of saying thank you, but I'd rather not?
I would very politely decline. I have no interest in getting a vaccine that has not been tested.
Finally, and very briefly, because we have gone on for a long time, there is a debate in the literature about which is more effective. T-cell immunity, possibly derived from other coronavirus infections, or the immunity that you get from antibodies. Can you shed some light on that for us?
Sure. So for most people, what is important to understand is immunity is very, very complicated. It's very complicated, and it's this interplay of various different parts of the immune system. But to be very simple about it, and to oversimplify a little bit, you can think of immunity having two arms: the antibody-mediated arm, and then a cellular immunity arm that comes from T cells. They are both very important, and they are differently important for different diseases. And what we know about the coronavirus, I believe, we have good evidence that both are very important. This is why, for instance, when we see studies with antibody levels coming down, I don't worry excessively, because we have good data that T-cell immunity is there as well and also matters. I don't really think we have enough evidence to say one is more important than the other. I also think all the data so far suggests that if you've been infected, you probably generate a good immune response of both kinds, antibody and T cell. And in general, I don't believe there's enough T cell immunity from other diseases that makes a majority of Indians or Americans somehow protected from this virus. It may be that there's a little bit of cross-reactivity enough to lessen the severity for some people. That may explain why some people have very mild disease or are asymptomatic. We don't know yet. That work is being sorted out. But in general, the good news is there are many parts of the immune response, and they all seem to be important in preventing this disease and preventing the severity of this disease.
Professor Jha, thank you very much for a comprehensive interview where you shed light on a range of subjects. I think for many people, this will be educative. I thank you. Take care. Stay safe.
Thank you very much for having me on. It's always a pleasure. Be well.
To receive instant updates on all videos from The Wire, click the subscribe button and hit the bell icon. Pay to support independent journalism. Click the link in the description and choose the amount you want to pay.